Good evening, everyone, and welcome to this presentation of improving the myopia controlling effect in Ortho-K treatment, which I think we can all agree, controlling myopia is still one of the hottest topics in eye care. And so I think tonight you're really going to get some information that is evidence-based, which I think is really important as we move forward in this field, as we try to really be more precise in how we control myopia and be more effective in doing it. I'm Dr. Bruce Morgan. I'm the Executive Director of Research and Clinical Support at Optical, and I'll be the moderator. So without further ado, I'd like to introduce someone who probably doesn't need a lot of introduction to some of you, but he has a special talent for orthokeratology, and he has been involved in treating myopia with Ortho-K for many, many years. And he is the Clinical Research and Development Director for Precision Technology Services and Cardinal Contact Lenses in Canada. He's also a research scientist and clinical instructor at the Pacific University College of Optometry and a clinical advisor to the CAT Design Group and Medmont Instruments. He's published numerous articles on various contact lens topics and has been a contributing member on a number of textbook chapters. He lectures globally and enjoys sharing his insights, methods, and research with eye care colleagues from around the world. He is a fellow of the American Academy of Optometry, the British Contact Lens Association, the Scleral Lens Education Society, and the International Academy of Orthokeratology. Please welcome Mr. Randy Kajima.
Hey, thanks a million, Bruce. And thank you to Optical for giving me an opportunity to share with you guys some thoughts about myopia control and where we might head today that's different from where we did a year ago, 2 years ago, 10 years ago. If we fit a patient in orthokeratology, we might get something that looks like this, the beautiful bullseye topography. And this, of course, is what we're really shooting for, is a well-centered treatment area, treatment that's larger than the pupil, gives us good quality of vision. But is this what we want for myopia control? And if you focus in on the action within the pupil, the powers that are distributed across the central cornea within the pupil, you get basically a 1 diopter add or a 1 diopter defocus. So while we gave this patient a 3 diopter myopic reduction, we have a 1 diopter, let's call it add power, if you think about soft multifocal lenses for myopia control. So not a very strong signal, a good Ortho-K effect, but not necessarily a good myopia control effect. Well, let's take this lens and put it on another patient, and we'll also achieve a 3 diopter effect, 3.03 diopters. But this time, the lens produces a 2 diopter defocus between the most minus in the center, 3 diopters, and the least minus at the pupil border, about 1 diopter. You're getting essentially a 2 diopter add power. Now, let's do this again on a third patient and place this Ortho-K lens on eye, create full effect. We've got a nice bullseye, but here we're creating our 3 diopter effect, but we're giving this patient a 3 diopter defocus, much different from the other 2 patients that we looked at. So when we do orthokeratology, we don't really know which patients that we're going to give a low defocus versus a high defocus to. We don't know which patients will have the low amount of spherical aberration or the high amount of spherical aberration. We do know that the bigger the treatment zone, the lower the defocus, the less the spherical aberration. The smaller the treatment zone, this blue area of myopic reduction or of flattening of the central cornea, the higher the add power or defocus we create, and the higher the spherical aberration. The greater the defocus and the greater the spherical aberration, the better the myopia controlling effect. So we want to try to control these Ortho-K lenses so that they produce the best myopia control. But how do we do that? Well, if we take conventional Ortho-K lenses and look at all of the peer review studies that were randomized, controlled, we see that we get about 50% less eye growth when we do Ortho-K. Now, that means that the average is 50%, but some patients may get basically no stopping of their axial growth, no hindering or slowing down of that eye growth. Some might get 100% control of their myopic increase or shift. So we do a pretty good job. We get about 50% less eye growth, but can we do better? That's the question. And how would we modify the lens parameters to achieve better than 50%? And that's really the question that our topic we intended to address tonight. Now, one of the ways that's been proposed, and it's actually was right here at Pacific University where I am right now, by the person who owns this home that I'm actually speaking from, Pat Caroline, proposed about 15 years ago that if we use different size optic zones, we might be able to better control the signal that we create for kids in their when we're trying to achieve myopia control, but also to use larger treatment zones for adults. So we reduce the aberrations and create better visual outcomes. So the point is that if we were to employ different optic zone sizes, we might be able to control the signal better and hopefully slow down eye growth. So this study was performed at Hong Kong Polytechnic in Hong Kong, and it was done by a couple, or guided by a couple of very famous researchers, Pauline Cho and Peggy Chung. You will know these names if you've read any myopia control research in orthokeratology. They're really, they gave us the beginning of our understanding that orthokeratology lenses slow down eye growth, and it's just been a plethora of studies that have come out of this site. And their PhD candidate, who's now a PhD after completing the VOLTZ study, Ella Guo, did all the heavy lifting in this study. And what they wanted to do was look at Chinese eyes, of course, the vast majority of patients in Hong Kong, patients under or up to 4 diopters of myopia, up to 2.5 diopters of astigmatism. So moderate myopia, but relatively high astigmatism, all Chinese patients. And we put them into a 5 mm optic zone on the one eye, our novel lens, and then a conventional 6 mm optic zone on the other eye. The one downside of this study was that it was performed through COVID and through the pro-democracy demonstrations that happened in Hong Kong. But somehow Ella managed to keep the study on the tracks, even in spite of the challenges of the optometry school is actually occupied by the demonstrators during the riots, and that completely shut down the optometry school for a number of months. So many of the patients we could not follow up properly, so they had to be dropped from the study. But we managed to get a healthy number of patients through the 2-year study. And essentially what we're doing is comparing a conventional 6 mm optic zone. This is the size of OZ that most orthokeratology lenses have today. They were designed well before the millennium. The idea being if you had a large 6 mm optic zone, you create a larger treatment zone, and therefore the patients will have good quality of vision. The patients at the time that we were fitting before the millennium were adults. It wasn't for myopia control. So the novel lens is a 5 mm OZ, and what you might see is the peak of the reservoir, the deepest point the fluid layer reaches, is closer into the center of the eye. So you're basically squeezing down peak to peak the highest point of the fluid layer and the resultant suction force. So you're comparing a 5 mm optic zone in some of the kids to a 6 mm optic zone in other children. Now, one of the things that Ella did was a really comprehensive look at various topographic metrics to try to connect, if we change the eye a certain way, does that create more or less signal for eye growth? So she did about 30 different data points of analysis, and she was able to narrow these down to these specific metrics that tell us or predict when we get good or bad myopia control. Now, to kind of simplify it, what we might say is that the treatment zone size from the 0 point to the 0 point, where you create no change. So looking down on the graph below, you notice you have this central flattening. We're reducing the radius of the eye. Then toward the mid periphery or toward the pupil border, we reach this point where there's no effect. It's basically zero change in the eye surface. That's the limit of the treatment zone. So central flattening, and then at the point where you reach zero effect, that's where your treatment zone ends. And what she found was the horizontal and vertical treatment zone was predictive of good or bad myopia control. The smaller the treatment zone, the better the myopia control. The larger the treatment zone, the worse the myopia control effect. And when we compared the two, the blue are your 6 millimeter optic zones. The orange are your results in patients with the 5 millimeter optic zone. On the left, you have the horizontal reading, the 0 to 0 across the horizontal axis, and on the right side is the readings along the vertical. And as you can tell, in both cases, the blue lines, the 6 millimeter optic zones, had a larger resultant treatment zone compared to the 5 millimeter. So there's a significant difference in how the corneal epithelium responded to orthokeratology when you use a large or small optic zone. No real surprise there. We've seen that happen for years. As we move that reservoir in, that decreases the treatment zone. As we move that reservoir out, it increases the treatment zone. But what's interesting is, for the first time, we understand how it's connected to myopia control. And again, the smaller the treatment zone that you can create, the better the myopia control. So if you've got a big, huge blue treatment area, that's going to likely give you good orthokeratology, but not necessarily good myopia control. One of the other findings was the surface area of the treatment zone was also found to be predictive of good or bad myopia control. Again, the smaller the surface area of that treatment zone, the better for myopia control. Now, this is a big deal, that we know where we want to go. We want to alter the parameters of the lens so that we can decrease the treatment zone. And that is easily done with a smaller optic zone. So simply going with the smaller OZ is a big piece of this puzzle to creating better myopia control. But what you'll probably be the most interested in is the axial elongation outcomes. And again, the blue are your patients, your kids in the 6 millimeter optic zone. The orange are your children in the 5 millimeter optic zone. And you can see at the end of 2 years, the patients in the 5 millimeter optic zone basically had less than half the eye growth of the conventional 6 millimeter optic zone. And it works out that a 5 millimeter optic zone lens gives you 78% less eye growth. Remember in the beginning, we said that 50% eye growth is the average of most of the studies that have been performed in Ortho-K, all of them using about a 6 millimeter optic zone. So simply by going smaller, we can increase the myopia controlling effect, getting almost as high as 80% less eye growth. Now, this is parallel to some of the research done in combination studies where you have a optical intervention like Ortho-K or soft multifocal plus atropine. really you can use a smaller optic zone and achieve pretty similar myopia controlling outcomes, again, and not using a pharmacological intervention. So super exciting. We know that we can create even better myopia control. And I don't think we're done yet. I think this is one step in improving the myopia control. I think we need to continue the research and see if even better myopia control is possible. So today, with the Moon lens, you have the ability to create different optics for patients, whether it's an adult or whether it's a child. Another finding that's very helpful to know is that the smaller optic zones are more effective at creating higher amounts of myopia. So not only do you get better myopia control with smaller optic zones, but you also can achieve higher amounts of spherical reduction and higher amounts of astigmatic reduction as well. And the astigmatic reduction is partly to do with creating an appropriate landing 360 degrees around, but you also can create higher amounts of hydraulic force over a smaller surface area with a small optic zone. So pretty exciting that we can alter how we fit orthokeratology using different parameters and create improved myopia control. And the Moon lens uses this technology of the hydraulic force controlling where it is, how high it is. This is the essence of how the Moon lens is customized. The Moon lens and the Hong Kong study, the novel design used in the Hong Kong study, uses the same OTZ technology, optimized treatment zone technology. And this is, put simply, is a way of calculating the appropriate tear layer profile, the shape and thickness of fluid for each patient based on their age, their eye shape, their RX, and the type of optics that we're trying to achieve, either lower amount of spherical aberration or higher amount of spherical aberration, myopia control or adult Ortho-K. Now, to understand some of these tear forces, it's kind of helpful to look at these tear profile graphs. And if you fit a patient with a one diopter myopia, or you want to create a 1 diopter reduction in myopia, 1 diopter flattening of the central cornea, this is the fluid layer that would be calculated to create that effect. You essentially get 26 microns of depth at the deepest point of the reservoir. Now, if you want to create more effect, if you want to create a 3 diopter effect, you get a flatter base curve to cornea relationship, you get a deeper reservoir, you get more hydraulic force, but you have the same apical clearance. You have about 7 microns in the center for both of these fits. Now, if you want to create even more effect, a 5 diopter effect, again, you have the same apical clearance, about 7 microns, but by using the flatter base curve to cornea relationship, you get a deeper reservoir, 77 microns. You have much more hydraulic force. So when you fit a low myope, you have a low amount of tear reservoir depth, in this case 26 microns, minus 3 would be 50 microns, minus 5 would be 77 microns. So as you increase the effect or the target amount that you want to achieve, you need to create a deeper and deeper reservoir. That's how you create more hydraulic force on the epithelium. That's how you create more effect. So here's a patient that has a 2 diopter RX change. And what you see is this very large treatment area that extends from pupil border to pupil border and just beyond. So you create this wide area of central, let's call it applanation, kind of like a refractive surgery outcome. We're going to create as large a treatment zone as possible. If we go up to a 9 diopter effect, then you can't create the same flattening over the same area. You have to create more flattening over a smaller surface area. So here with a 9 diopter effect, you'll notice that your treatment zone gets much smaller, that blue area of flattening. And when you look at the graph, you see this more V-shaped pattern where we have a great deal of effect in the center, and then that change is lost very quickly as you go back to zero as you go back to the treatment zone junction. So the higher the refractive change that you attempt to achieve, the smaller the treatment zone becomes. And we know from the VOLTZ study that the smaller the treatment zone, the better the myopia control. So we don't necessarily want to create a big, huge treatment zone on our -1 and -2 patients. We need a way to manipulate that so that we can create that maximized myopia control signal. Now, again, with the various RX changes, you can control that hydraulic force. So just by creating a flatter and flatter base curve, you create more hydraulic force, you create more change on the corneal epithelium. There's another way to approach this so that we don't have to go flatter and flatter in base curve and take the patient more into the plus to create good myopia control. What we can do is use an aspheric base curve. So here's an example of the tear layer profile with a patient in an Ortho-K lens with a spherical base curve. So the base curve radii is the same all the way along from center to optic zone junction. What that does is create a 44 micron fluid layer. Now, I want to put on a lens with an aspheric base curve. So this is now the same radius in the center. It will create the same mold shape. It'll create the same effect that we want or target that we want for the patient. But notice with the aspheric base curve, you get a thicker fluid layer. Your tear reservoir depth is up by about 50%. We're at 63 microns. So by using a aspheric radii in the optic zone of the lens or the base curve of the lens, you can make that tear reservoir depth higher, giving you more hydraulic force, giving you a higher signal to slow down eye growth. Another example would be if we had a low myope like this, a -1 target. Remember we said we create a very small fluid thickness or low amount of fluid depth, so a low amount of hydraulic force. That's if you use a spherical base curve. What if I were to put this patient into a slightly higher asphericity? So I'm still targeting -1 effect, but by increasing the asphericity, I can make the fluid layer thicken up to 40 microns from 25. If I go with an even higher asphericity, we can get up to 60 microns on this same one diopter effect. So in the center, we're still going to create that one diopter of flattening, but by having stronger suction forces in the periphery, we're going to squeeze down that treatment zone and create better myopia control signal. So these are important combinations that go together. The Moon lens incorporates not only the various optic zone sizes specific to each patient, each age, each shape, each RX, but you're also using asphericity in the base curve to target the appropriate amount of hydraulic force to create that stronger signal or to decrease that signal. As an example, if you were fitting an adult in Ortho-K, and the research suggests that we fit about 15% of patients are adults in orthokeratology. We don't want them to have a tiny treatment zone. They're going to have aberrations. They're going to have flare and glare. They're going to complain about their vision and probably wash out of Ortho-K. We want them in the big optic zone. But the kids, we want them in the smaller optic zones with the high asphericity, creating that better myopia control signal. So the Moon lens is a pretty exciting product in orthokeratology, not just because it's a good Ortho-K lens, but because you can customize it for each individual eye, not based on just Ortho-K, but whether you want good myopia control or you want better optics for adults. So each lens is customized based on the age, the RX, the eye size, the diameter, the shape, the toricity of the eye, and then finally the visual needs. So this is a very highly customized orthokeratology lens. However, it's very easy to get your head around. It's very easy to understand. There are three principal zones that you're concerned with. the base curve, the reverse zone, and the alignment zone. And we'll break down each so that you can understand how they function. The first thing that we want to do in the moon lens is measure the visible iris diameter. We want to design the appropriate size of lens for the size of eye. We don't want to put a 10/6 lens on a 13 millimeter cornea. We don't want to put an 11 millimeter lens on a 10.8 cornea. So basically it's VID minus 0.8. So if you have a normal 11.8 visible iris diameter, you would start with an 11 millimeter moon lens. So quite simple and straightforward. The idea being, let's get the right diameter on every patient. The second is optic zone and base curve selection. And this, of course, will be based on the Jessen factor. So if we want 3 diopters flattening, we're going to use a base curve 3.5 diopters flatter. We're going to add in that fudge factor of a half diopter to try to take that patient to a flattening that gives them plus 50 AM vision after removal. Now, the base curve is important, but remember the optic zone is also super important. So we're going to choose the optic zone appropriate for that particular case. And the way that's done is using this simple chart. Actually, the software does all this, but we'll get to that. If you're dealing with a patient that's young, and this is a myopia control candidate, then we would use a 5.5 millimeter optic zone for patients 3.75 diopters or less. We would also use the 5.5 optic zone if your patient were up to 5.75. So basically, if you're myopia control, we're using a smaller than 6 millimeter optic zone for most RXs. You'll go down to a 5 millimeter optic zone when the myopia is exceptionally high, 6 diopters or greater. Now, for adults, we want to favor using the larger optic zone where possible because we know that will give the patient less aberrations, better quality of vision. But as the myopia increases, it will be easier to achieve the effect with a smaller optic zone. So you'll use the smaller OZ as you get to higher and higher RX changes. So basically, you're using the optic zone appropriate for the age of patient and then the RX. Now, the next zone in the lens is the reverse curve zone or RCD, and its function is really only to provide the appropriate apical clearance. So when we use that flat base curve with that high asphericity or no asphericity, how steep or deep does the reverse curve need to be to give us 7 microns of fluid under the center? Nothing you need to worry about, all calculated by the software or by the Art Optical team to give you the appropriate lens parameters. But what the reverse curve depth is going to do, again, is going to target 7 microns of fluid layer between the apex of the back of the lens and the apex of the cornea. And that can be adjusted in 1 micron increments. And as you probably know, orthokeratology is a lens of microns. A scleral lens, like the ampullae, is a lens of hundreds of microns. You know, we make big jumps in the steps by, 25, 50, 100. But orthokeratology is all about microns. If you want to change, it's usually a relatively small amount, like 5 to 10 microns of change. So with the moon lens, you're able to alter it in 1 micron increments if you absolutely needed to. Now, the next zone out in the lens and the next zone that we're concerned with is the alignment zone angle, or AZA. And the principal function of this zone is to provide the centration, the edge lift, the comfort, the ability to remove it, and a healthy lens to surface relationship, a healthy response. In my mind, and Bruce might agree with me, the alignment zone is maybe the most important part of the orthokeratology lens and certainly of the moon lens. If we get the alignment zone angle right, we get the centration right, we get the fit right, we get the effect right. Now, the alignment zone angle is altered in degrees. So a 1 degree change in the angle is a fairly significant adjustment. That should create a big alteration to the fit. But you can adjust it in as small as 0.01 degree steps. So the Moon Lens allows that finite customization that is available to you and available to the consultants to assist, make sure that you're getting the right lens to surface relationship, the right edge lift, the right landing, the right comfort. Now, this alignment zone angle is one that you're probably going to modify with a reasonable amount of frequency. And, it's if you need a change in edge lift, if you needed a change in centration of the lens, we're probably going to use this zone relatively frequently to make those adjustments to really improve upon the fit. But I might rely heavily on the art optical consultants because they're really the experts at looking at the pattern. If you can send them a photo of your findings or share with them what that edge lift appears to be, and they'll know exactly how to adjust it. But as I said, typical adjustments are 1 degree increments. Now, one of the things that we do with Moon Lens that's I think very special is to look at the peripheral corneal astigmatism or toricity of the peripheral cornea. And what essentially you're doing is measuring the sagittal depth along the flat and then the steep meridian. And the idea is not to understand the central K readings, what is the corneal astigmatism at 3 millimeters, but understand the astigmatism and the depth, where you're going to land the lens, where the alignment zone angle is going to touch down. And for this patient, there's a 36 micron difference between the height of the eye along the flat meridian and the height of the eye along the steep meridian. We're 36 microns deeper running vertically. Now, what does that mean to you? Well, when you're around 30 microns or greater, when your sagittal differentials 30 microns or greater, that's typically the point where a symmetric non-toric landing lens starts to perform a little bit wonky. It's not as ideal as you would like it. You might see more rocking of the lens back and forth across that steep meridian. You might see a lens that's moving more, that's decentering more, that isn't creating the comfort, the effect. So at 30 microns, that's where the Moon Lens is going to choose a toric landing. So one of the unique features of this Moon Lens and its toricity is Art Optical is going to send you a toric lens for every patient that comes even close to needing a toric. And the price is the same whether you need whether a symmetric or a toric is called for. So that's a really nice benefit for each of our patients, because we're not choosing, do we pay the extra money for a toric lens for this patient when they're really borderline? They might be able to fit well into a symmetric lens. There is never a downside to forcing a toric lens on an eye that has even a small amount of toricity. You just improve the peripheral alignment. My daughter, I fit her in orthokeratology, she was, I think it was 27 microns of height differential. So she didn't make that 30 micron threshold, but I have never seen an adverse outcome come from having better landing, better alignment 360 degrees around. So I fit her in a toric with 27 microns of toricity. So the point just being, use a toric as often as possible. And the Moon Lens is going to encourage you to use a toric whenever that patient is close to that threshold of a symmetric or toric working. 30 microns or greater, you're going to get a toric landing Moon Lens. Now, you might say to yourself, I've dealt with a few orthokeratology lenses. If I just send the data, the lab can make the lens for me. That's relatively easy. I'm not sure I understand how to do all this customization, creating a customized optic zone, a customized asphericity, sagittal depth, toricity, edge lift, all of these things highly customized. Well, it's actually very simple to use the software to do all this work. You do not have to be an expert at designing an Ortho-K lens. You don't have to be one of the consultants to do this. You can rely on what's called the CAT Cloud platform. The Moon lens was developed by the CAT Design Group. The CAT Cloud platform is a software that was developed by the CAT Design Group to help fit the Moon lens. And what it does is it takes the corneal topography, your topography, you upload it to the CAT Cloud platform, and it's going to do all of the heavy lifting. It's going to design all of that customization that we talked about to create the initial Moon lens order. Now, once you fit the lens, a high percentage of the time, we're going to have first fit success. Generally, I find about 80% or north of the time we have the ideal outcome. We have first fit success. 20% of the time, we might have high lid tension forces. We might slightly undercorrect the patient, need a little bit of tweaking, or see a little bit of staining at the edge. We might need to tweak the edge lift. In orthokeratology, we never know what we're going to get. So you need an ability to manipulate the lens parameters to optimize the outcome. And this CAT Cloud platform was designed so that you could problem solve when the lens needs fixing. So certainly the Art Optical consultants are experts at taking your findings and assisting through the process of optimizing the parameters, but you can actually do this on the platform yourself if you want to, and it's super simple. So we'll take you through a couple quick cases so you can see how it works. I'm going to take my topographies. I'm going to click on the Cloud Link icon that's embedded into my topographer's software. Excuse me. Then that is going to automatically send all of the thousands of data points from my corneal topography right into the CAT Cloud platform. So I don't need to do any kind of manual upload. I don't need to do any manual collection of data to come up with a lens. It's just all going to be collected automatically by the software. Now, after the topographies are uploaded along with the RX and the patient data like date of birth, we're going to know what is the target for this patient? What is the kind of customization we need to the optic zone, the sag, the landing, the toricity, all of those things. So let's build a Moon lens from our best topographies. And ideally, the limiting factor for you is how good your maps are. So take the best quality maps that you possibly can. If the patient is struggling with that initial topography capture, and they're just intimidated by the instrument getting close to them, or all these new procedures, a new office, a new doctor, all of these things, if you have to, bring them back a second day. I've found with some kids, I've gotten much better topography just because they were more used to the instrument at that point. They were more steady. Remember, we're trying to fit a lens to be micron accurate. So again, creating the best, capturing the best possible topographies is really to your benefit. It's going to improve your first fit success and the overall outcome for both you, the parents, and the practice and the patient. Now here is our right eye uploaded, and I'll bring your attention to a couple of things. You'll notice that the RX is here, and your therapy target here, your visible iris diameter, and then all of the data from the topography that's been pulled off the topography. So all of this information is uploaded by the topography. I didn't have to enter in anything at all. And I'll bring your attention to this age. The age of patient is 8 years of age, 8 years old. And you'll notice that a 5.5 millimeter optic zone has been selected. So we've selected a myopia controlling size optic zone based on this patient's age and RX. Then the visible iris diameter is 11.5, and the lens diameter that's chosen is therefore a 10.7. Remember, VID minus 0.8 will give you your Moon lens diameter. And then finally, the sagittal differential is 26 microns, below that 30 micron threshold of sagittal differential in the periphery of the cornea. So therefore, a symmetric landing lens is chosen. So all of these things were just automatically done by the software. You did not have to do anything to arrive at the final lens parameters. Now, if you wanted to, if you're a bit of a tweaker, you love to manipulate parameters of your all of your contact lenses, you can do that. You can click edit and just change any of the data if you wanted to. But I would say almost completely unnecessary. Just if you have good topography uploaded, just trust the system to design the right first lens. Now, here's the left eye, and slightly different from the right eye. We still have an 8-year-old patient, so of course we have the 5.5 optic zone, but you'll notice the sagittal differential slightly lower, 19 microns. So we're still choosing that symmetric landing, and then the visible iris diameter 11.5. So we're going to have that same 10.7 lens. So we're going to use all of this topography data for right and left eye to design a lens that's specific to each eye. It's not generalized in the alignment zone, not generalized in the SAG or the RX. It's customized for each patient. So some of this data, the flat radius at the center, the flat eccentricity, the steep radius at the center, the steep eccentricity, relatively easy data to pull out of your topographer, but you don't have to do it with the CAT Cloud software. You just upload the topography, and again, the software just does all the work. So it's really quite an efficient and easy system to use. Now, when it's all said and done, then you can send the order directly to Art Optical. You can click this little box here to request consultation. If this is the first time that you've done an Ortho-K patient and you want Bethany and the consultation team to just have a second set of eyes on it to make sure you've done it right, you can just click that box. It goes straight to the consultant. If that box is unchecked and you click submit, it's going to go to customer service. They're going to process the order and send it to you. So it's all automated by the system. It automatically reports the order to Art Optical. It sends you an email confirmation that it's been successfully completed and Art's been informed. So a very comprehensive system for managing the patient. Now, all of that customization has been achieved simply through all of that automation. So it's really relieving to know that you don't have to mess around with third-party software, looking at the tier layer profile, manipulating control points. It's a very easy way to create a highly customized moon lens. So if you're an experienced orthokeratologist, do you need the moon lens and the moon lens software? Maybe not. Maybe you can create your own custom lens by using your topographer, your fitting software. But I don't know that you could do it as efficiently as the moon lens and the CAT Cloud together. I'm an advocate of designing all of my own Ortho-K lenses. Our resident here at Pacific University, we teach them how to design Ortho-K lenses from the ground up. But in a busy practice like yours, chances are this is something that would be beneficial to you, even if you're a very experienced orthokeratologist. Literally within seconds, the design has been uploaded, it's been sent off to Art Optical, and you have this highly customized moon lens. Now, if you're a neophyte to orthokeratology, then of course this system will appeal to you because you're able to build a lens that is as customized as you almost possibly can in orthokeratology. And you're doing that with literally just a click of the button. It does come down to good topography. So you might work with the Art Optical consultants in the beginning, have them double check your topography and provide assistance on, have you achieved an appropriate diameter vertically? Are the lids and the eyelash shadows in the way, hindering the data? Is the quality of the calculation of the topography, is it hindered by in a flaw in the reflection of the placido, or is your topography just a rogue reading? Art Optical can be really helpful with it. The consultants are absolute experts at Ortho-K and understanding, how to achieve optimal outcomes. Now, in any lens, there's a post-wear outcome to evaluate, and in any lens, there's going to be times where you need to manipulate it. And how do you do that when you have a smiley face outcome, a high riding lens, or a frowny face outcome, a low riding lens, or staining on the peripheral cornea, or an under or an overcorrection? How do you alter the parameters of a Ortho-K lens or of a Moon lens to optimize the fit? Well, we're guided by these topographical outcomes. Bullseye tells us that we have a well-centered outcome. A central island where you have this apical steepening tells us that our lens is too far off the eye. We need to lower the sagittal depth. A frowny face tells us that we have almost a perfect bullseye. The hydraulic force is good, but the alignment zone is too tight. It's causing the lens to ride low. A smiley face would be opposite, where you're creating myopic reduction, but the alignment zone of the lens is too loose. The lens is riding too high. The treatment zone is high. And then finally, your lateral displacement. How do you drag the lens more onto lateral centration? So these topographies are how we assess the post-wear outcome in orthokeratology and in the Moon lens. And they also guide how we might fine-tune the fit to create the best possible outcome. And that's where we might go back to the Cat Cloud platform, and we would upload our post-wear topography, our post-treatment topography. And then we use that to compare our actual findings to the gallery of findings that exist in the Moon lens software. So what the platform does is it walks you through how to fix what might be slightly out. Is it undercorrecting? Is it overcorrecting? Is it high? Is it low? The software is going to walk you through with just a few clicks how to do that. And basically, you're uploading your topography and telling the software what's happening. So in this case, I have a bullseye topography, but I'm undercorrecting by a diopter. So I just punch in, I need an extra -1. The software will manipulate the Moon lens parameters to create the extra hydraulic force so that the next lens will achieve the target that we're looking for. If we have a central island outcome, a smiley face outcome, a frowny face outcome, we upload those topographies to the site and we compare them to the gallery. You'll see these little tabs here. You have bullseye, central island, smiley face, frowny face, lateral displacement. You compare your outcome to the gallery and figure out which is most like my outcome. Certainly here with central corneal steepening, this would look like a central island. Then you decide, is it a mild, moderate, or severe outcome? So in every case, we're going to use this platform both to design the initial outcome, but also to problem solve when things aren't working perfectly. And we're going to go through some of this post-wear manipulation in the upcoming webinar. So the second webinar is on users who have a topographer that's linked to the Cat Cloud platform. The third installment is for practitioners who don't have a topographer that will directly upload or link to the Moon lens, the Cat Cloud site to build their Moon lenses from. So number 2 is for linked topographers. Number 3 is for those that don't. And the Art Optical team can tell you whether your topographer will link or needs to be done more manually. Now, this platform is one that just makes orthokeratology so efficient. That might be its strongest asset, but certainly accuracy. The Hong Kong Poly study showed that the first study was a 94% first fit success. The second Hong Kong study, a slightly different approach, but using the Cat Cloud platform, had a 97% first fit success. So using a linked topographer with the Cat Cloud platform can create an incredibly high first fit success. Now, I'm not going to suggest to you that you can achieve 97%. Maybe you can. At a controlled site like a Hong Kong Polytechnic, where they have a very rigid protocol for who gets selected for the study. They're going to be a little more selective based on the topography, the RX, and so on. However, you can achieve a very high level of first fit success if you take good topography, upload it to the cloud, let the platform do its thing, and it'll design the appropriate moon lens for you the vast majority of the time. Then, if you need to tweak it, if you need to squeeze out a little more effect, if you need to move the treatment zone up, down, or laterally, the platform is going to help you through that. Now, hopefully this hasn't sounded too confusing. I know orthokeratology, for somebody who's new to it, it can be a very intimidating procedure, but it's really not when you have a partner like Art Optical, when you have experts like Bethany and the contact lens team, the consultant team there. They can walk you through everything. They can review your topographies with you to make sure you have good quality maps to build your lens from and that you're likely to have high first fit success. They can assist with designing that initial lens for you. They can assist with the problem solving. So we rely on them very heavily to assist us when there are things that we're not quite sure about. We reach the team and they always have the answers for us. So rely on your Art Optical consultant, especially in your first few cases. That will really help. So hopefully this has made some sense to you that it's kind of an exciting time in orthokeratology because we don't have to be satisfied with 50% less eye growth. We can slow down the eye even more. With a design like the moon lens, we might be able to get upwards of almost 80% less eye growth. That is very impressive in myopia control, certainly for an optical intervention. But the design is not only a lens, it's also a platform that Art Optical can provide you both the lens and the CAT Cloud platform that work synergistically with each other to make orthokeratology simple, to make it efficient, to make it accurate. So their team can really assist you through this process.